My name's Byrne, and I am lead pharmacist for anticoagulation at King's College Hospital, and I'll be presenting with Vicky Collings, who is consultant pharmacist for hemostasis and thrombosis at Guy's and St Thomas's. And we're presenting on behalf of the UK Clinical Pharmacists Association. We're on the committee for the Hemostasis, Anticoagulation and Thrombosis group. It's a really good resource for getting expert advice, education sessions and that kind of thing. So it's really well worth taking a look at their website and joining. There are, of course, other groups that you can join as well in different specialities, but it is well worth taking a look. Okay, so we're going to talk about anticoagulation stewardship and VTE treatment, and I'll start running through basically what anticoagulation stewardship is, and then we'll talk about VTE treatment and then how the two can be related together, basically. So firstly, my slides are moving. Yeah. So what is anticoagulation stewardship? Well, the definition is that it's a coordinated, efficient, and sustainable initiative to achieve optimal anticoagulation-related health outcomes. But really, it's not a new concept, particularly. This actual term, I think, was probably coined by the Anticoagulation Forum in the US. They published a document in 2022 called Advancing Anticoagulation Stewardship. It's really based around work that previously had been done on antibiotic stewardship. It is not a groundbreaking concept, and actually, we've in our roles as anticoag specialists and in most institutions, hospitals, whatever, there are people doing this stuff all the time, this stewardship role. It's basically what our job is. And in some ways, we're ahead of, even though the US have kind of coined the phrase, we're ahead of them in some ways that have been doing this kind of thing for a while. We just haven't badged it under the umbrella of anticoagulation stewardship. So it's not a big mystery. It's what we're all doing, but it's quite useful. The document they've produced is quite useful, a quite useful reference for the things to think about when you're trying to improve anticoag safety. It provides loads of tools and resources. So if you're looking up anticoag stewardship under the Anticoag Forum, they've got loads of tools and stuff to use there. Okay, so why do we need it? Well, we all know anticoagulants are high-risk medications, and we know that anticoag-related errors can result in bleeding and thrombotic events. And some of these anticoag stewardship programs have shown that you can improve quality and safety of anticoagulant use and improve clinical outcomes. So that's why we want to do it. And as I said before, it builds on the concept of antibiotic stewardship. It's a holistic approach which spans the whole of care. It's been shown to reduce bleeding events and hospital admissions and length of stay. And I think the reason that it was started was because, let's look at this graph on the next page, that you can see from here when they introduced antibiotic stewardship, this is all US data, admissions to ED reduced. So, well, I mean, we don't know whether it's necessarily as a result of that, but it shows that there was a reduction in these incidents, in these people being admitted to ED for adverse incidents associated with antibiotics. And all the while, adverse incidents associated with anticoagulants were increasing. So it's felt this was another area where something should be done, and using the sort of template of the antibiotic stewardship program. So more specific reasons that we need anticoagulation stewardship. We know that there's a lot of inappropriate dosing, especially for DOACs, especially with underdosing, particularly for apixaban, inappropriate dose adjustment, side effects that we're dealing with on a daily basis, lack of monitoring. I mean, the list goes on. The areas that we can intervene and use anticoagulation stewardship are sort of endless in anticoagulation. So the Anticoag Forum came up with these main core elements, some of which are more or less relevant to us in the NHS. Leadership and accountability is the first one, and that's really talking around getting partnership with the key stakeholders within your trust or wherever. For instance, we engage quite closely with the medicines risk groups, all those kind of things to try and secure anticoagulation stewardship, obviously involving the MDT, using a diverse range of specialists across departments and in collaboration with other specialists. Systemic care, so safety and quality, implementing policies, procedures, guidelines across the system, really, and using clinical decision support and risk assessment tools, for instance, like we do for VTE risk assessment. And then education is a big part of this, and that's a big part that the UKCPA is involved in that area of anticoag stewardship in education. So this is for staff, which is a lot of what we do, and then for patients as well, having lots of education available for patients too. Professional accountability, they cite using expert teams and that people have access to expert specialist knowledge. And then performing lots of data collection, creation of data collection tools and performance reports to inform the areas that you need to work on, I guess. And then there's a lot of focus there on the transitions of care where we know there's high risk with anticoagulation. So they talk about clearly defined roles and responsibilities for clinicians, e.g. who follows up when someone has a PE, who follows them up and who decides on how long they're going to stay on anticoagulation for. So those kind of things, and that's just how they've categorized them. So some examples of the things that we do on a daily basis is the DOAC anticoagulation clinics. We don't have a DOAC or anticoagulation dashboard as such, but some people do. And I know my colleague's just been to Boston to visit a hospital there, and they had some dashboards for safety for anticoagulation. Guidelines on anticoagulation monitoring, which we have, and most hospitals have. Clinical decision support, which in some ways is embedded to most electronics systems, but maybe not as well as we'd like. MDT reviews with teams and collaborative working, transitions of care, as I spoke about before, so providing anticoagulant related information, evidence reviews, and then HAT and incident reviews. So these are some of the kind of things that are going on in all hospitals at the moment. They're signs of kind of examples of successes in terms of anticoagulation stewardship. So in terms of the treatment of VTE, this is the NICE guidance. It's not a great slide, sorry, there's quite a lot of information on that. The NICE guidance recommends apixaban or rivaroxaban as first line. And this is because these two, apart from being generic, but they do not require any low molecular weight heparin up front. So in that sense, they're preferred. It also gives some information on cancer-associated thrombosis and the treatments of choice, which I won't go into in detail here, and for antiphospholipid syndrome. It doesn't cover dosing. It's just a kind of crib sheet for what should be prescribed when. I'm going to focus on DOACs for VTE as they're mainly what we use now. And just really the common pitfall, so where we can intervene with anticoagulation stewardship, like looking at what often goes wrong, I guess. So the choice of DOAC versus warfarin, DOAC dosing and use at extremes of body weight, use in high clearance, and use with patients on drug interactions. So firstly, before we start someone on a DOAC, we're checking quite a few things. We're checking that it's okay for them to have the DOAC, and then if they do have the DOAC, what dose they would need. So creatinine clearance, weight, LFTs, full blood count, and a lot of these things are to work out what the bleeding risk of the patient is, the underlying coagulation screen, what the indication is for anticoagulation, whether this is actually licensed and suitable for this patient, and then their bleeding history, obviously, and their medication history for interacting medication. So in terms of who can have a DOAC, it's not that clear cut. So the licenses for VTE is for the treatment of specifically DVT or PE and for the secondary prevention of DVT or PE at lower doses. So different people interpret this in different ways. If you stick strictly to the license, you just be using it for DVT or PE. But we know that we're using it in a lot more areas than that. So for antiphospholipid syndrome, we do sometimes use DOACs for patients who are single or dual positive, not for triple positive patients. So really within antiphospholipid syndrome, we will give a DOAC to a patient who is not as high risk for thrombosis. And that, I mean, I put a question mark by all of these because we're not sure, and sometimes we do, and it's very individual based decision to use a DOAC. For a patient with a massive P in the acute stage, we might want to use low molecular weight heparin. It's weight based. If we're worried in any way that they might not be getting the required amount of DOAC. unusual site VTE. So this is where the interpretation of DVT-PE is sometimes stretched to other veins. So portal vein, cerebral venous sinus thrombosis, we do use DOACs in those patients. We might use warfarin first line, but if there's any, and often there is, reason not to use warfarin, there's many reasons not to use warfarin, but then we would tend to use a DOAC. We've become a lot more relaxed with liver dysfunction. So the SBC will say it's cautioned with AST over 2 or bilirubin over 1.5 times the upper limit of normal. But we would probably still use DOACs with careful monitoring in some of those patients. And according to the International Society of Thrombosis and Hemostasis, there is no weight limit for rivaroxaban and apixaban for the treatment of VTE. They don't comment on the treatment for AF, but for VTE. So theoretically, you can use a DOAC up to any weight without any monitoring. But in practice, we are a bit more cautious than that. And in an acute stage for a big PE, for instance, we would be a little bit more cautious, and we might use low molecular weight heparin, upfront for a period of time and then switch to a DOAC. Or we may use warfarin even. The times you really can't use a DOAC or where there are interacting drugs, so significant interactions, like especially with the inducers, when someone's got an acute VTE, you don't want their exposure to be lower than you need it to be. So phenytoin, carbamazepine, rifampicin, those CYP3A4 inducers, we can't monitor, so we have to use warfarin in those patients or low molecular weight heparin. Creatinine clearance under 15, we wouldn't use a DOAC usually. For dialysis patients, we do sometimes use apixaban 2.5 milligrams twice a day. And that's becoming more common, and that is with dose monitoring in a specialist centre. Triple positive antiphospholipid syndrome, we do not use DOACs in. And as I said, massive Ps in high body weight patients, we'd be a bit more cautious about going straight in with a DOAC. Okay. This is just a table really here for the dosing, just to highlight that for rivaroxaban, there's not a formal dose reduction, but there is a dose reduction. It's kind of woolly for increased bleeding risk. And the edoxaban is the only DOAC that for VTE has a formal dose reduction. And you can see that the dosing is very different from AF. And you've got loading doses for rivaroxaban and apixaban, and then upfront low molecular weight heparin for edoxaban and dabigatran, which makes them maybe less attractive for the use of VTE, because you're obviously having to give a subcut injection for 5 days. Having said that, quite often patients have had 5 days of low molecular weight heparin on our wards, and then we can just switch them to edoxaban, so we do that sometimes. So I think really the most important thing for this is there is no formal dose reduction for rivaroxaban or apixaban in VTE, and I think that's common misconception. And we hardly ever use rivaroxaban 15 milligrams for the treatment of VTE. And if you're thinking about reducing the dose, you probably should be thinking about using a different drug. I'll go into this in more detail on the next slide. So these are the nuances really of DOAC dosing for VTE. Don't confuse it with AF dosing. It's not the same. There is no role for apixaban 2.5 milligrams BD in the treatment of acute VTE. It should never be prescribed. We don't know that it works. And I think sometimes that gets missed and people get confused with the AF dosing. So there is, for apixaban, you give the loading dose of 10 milligrams twice a day, and then you give 5 milligrams twice a day after a week. And there is no dose reduction. We don't use rivaroxaban for low body weight patients or patients with low creatinine clearance. We don't want to give 15 milligrams twice a day of rivaroxaban for 3 weeks if their creatinine clearance is low. And we have other options. We'd be worried about accumulation in those patients, so rivaroxaban is not the drug we would choose there. Low molecular weight heparin can replace DOAC. So if patients had a week of low molecular weight heparin, you can then give rivaroxaban then for 2 weeks. So you've got a 3-week loading dose. You can have a week of low molecular weight heparin and then 2 weeks of riv. Or if you're worried about the high loading dose for apixaban or rivaroxaban, you could replace it with weight and renal adjusted low molecular weight heparin, and that's a way around that. And then edoxaban in high clearance. Well, I'll talk about that later. Sorry, I'll come on to that later. I've got a slide on that. And then your doxaban can be quite useful in these patients because you've got a dose reduction for weight, so low body weight patients and low creatinine clearance patients, your doxaban can be quite useful because at least there is a formal dose reduction. Okay, so coming back to high body weight, ISTH, so International Society of Thrombosis and Hemostasis, recommends standard dosing with no drug level monitoring for rivaroxaban and apixaban. And I've used these nice little drawings from an illustrated review that some of my colleagues did. Basically, the outcome of looking at pharmacokinetic studies and real world data is basically that weight does not have a clinically relevant influence on rivaroxaban or apixaban exposure from the PK studies, and this is backed up by the real world data. So we don't see an increase in recurrent VTE in high body weight patients on DOACs at standard dose, and which is why ISTH have come to this conclusion. ISTH does not recommend the use of edoxaban or dabigatran because there's limited data. So really, if you're thinking about extremes of body weight patients, apixaban, rivaroxaban are your drugs of choice. There are patients that we would maybe monitor if they were particularly high body weight, or we were particularly worried that we wanted them to have a certain level of exposure of the drug. They were particularly high risk, then we may monitor them, but mostly there are no limits on that, which is not the case for extreme low body weight, unfortunately. There's little data on this. There's no international guidance to direct your choice or dose of DOAC. These low body weight patients are unrepresented in the phase 3 or real world studies. Obviously, the main concern is that bleeding and drug accumulation. And for VT, there's no dose reduction, as I've said lots of times, for apixaban, rivaroxaban, and dabigatran. So really, for these low body weight patients, we're looking at using either apixaban or edoxaban. And then edoxaban in patients with high clearance, which I know is something that causes people a lot of discussion. The FDA in America restricts the use of edoxaban in patients with a creatinine clearance over 95 mils per minute. That's only for AF, though. And then in Europe, edoxaban should only be used in high clearance after careful evaluation of the thrombotic and bleeding risk, which is a bit more woolly. This is because in the Engage AF trial, which is the licensing trial for edoxaban in AF, there was a trend, and remember this is AF, a trend to reduced efficacy when the creatinine clearance was over 95 mils per minute. So this is an excess of stroke, but a trend. And the relevance to the VTE population is obviously uncertain because it wasn't in that same population. Obviously, the worry is that increased clearance could lead to decreased half-life and decreased drug exposure and increased risk of thrombosis. To be honest, that's a reason to use, I guess, apixaban and rivaroxaban, which are generic, so cheaper anyway. And we think really there's a similar trend probably for all the anti-10A inhibitors, certainly a similar trend seen in Rocket AF. And the problem probably for edoxaban is that they put it on their SPC and it says caution in high clearance on the SPC for edoxaban. So we do have to think about it, probably just in patients with AF, but not be too worried about it. Edoxaban also can be useful to use in patients on interacting medications. So patients, particularly patients on HIV protease inhibitors, even in those with high clearance, which you might think it would then balance out the effect of the two things. And then we would usually monitor their levels. In terms of interactions, the problem with DOACs and interactions is you don't monitor, unlike warfarin. So you can't, if you've got a significant drug interaction where you're worried about too high or too low exposure of the medication, of the DOAC, then you can't really use it. That's for pharmacokinetic interactions, obviously. So I sort of think of this in the way of what patients are most likely to be on interacting drugs. So patients with HIV who have undergone, or patients who have undergone organ transplantation, infection, patients with malignancy or epilepsy, and these are the kind of those patients are on the kind of drugs that tend to interact. But especially for malignancy, there's an ongoing list of new drugs coming out, and we have to sort of check them case by case, really. And some of them we'll have to work out from sort of first principles whether we think they're going to interact or not. There's a really good sort of flow chart, I guess, on the Anticoag Forum website about how to work through whether a drug would interact with the DOAC and whether you could use it or not. It's really useful. There are some websites you can also use. The Liverpool HIV Interactions website is brilliant. The cancer drugs one is good too, but it's been archived. So the information on it is right, but then new drugs aren't being added. So you find quite a lot of the new drugs that you're wanting to look up aren't there. And then it's about going back to first principles to see working out how it's metabolized, whether it would interact or not. Pharmacodynamic interactions. So N says obviously avoid as much as possible, like for all anticoagulation, and try alternatives. Single antiplatelets, check indication. Mostly we're stopping. So mostly patients aren't on aspirin with a DOAC for VTE. If they haven't had an MI or cardiac surgery in the last year and no history of peripheral vascular disease. Sometimes we check with cardiology, but quite often we can make that decision. And then if they're on short-term anticoagulation, we just make sure they restart the aspirin when they stop. And then patients on dual antiplatelet therapy, they should never be on what's called, I guess, triple therapy with a DOAC and dual antiplatelet therapy long-term, but they may be on it for 3 months or so. And that would be only patients who are post-PCI with an indication for anticoagulation. And we don't use triple therapy with ticagrelor or prasugrel. And the max usual duration is 3 months, as I've said, and we would usually use a PPI for those patients. And again, it's just making sure that if the anticoagulation, the DOAC is just for 3 months, then restarting them on the aspirin or the aspirin and clopidogrel afterwards. Oh, I'll hand over to Vicky.
Thanks, Ros. Thank you. So I'm going to carry on a little bit more about stewardship and the use of electronic systems. So most organizations now over the last kind of 5 to 10 years have launched both electronic prescribing and e-health record systems. And this really revolutionized the way we can use the systems to improve safety, so for stewardship, for anticoagulation, but other kind of areas, and also improve the amount of healthcare data that we can access. So I'm just going to run through some sort of VTE specific examples. So I suppose VTE risk assessment being one of the first things that is done when the patients are admitted to the hospital. There's a nice little alert here that came from as a Cerner system, pops up saying you need to do the VTE risk assessment when the patient gets admitted to a ward. Here at King's and at GSTT, we have a hard stop, which means that certain other processes can't be completed until the VTE risk assessment is actually completed. And the risk assessment tool itself is on the computer, and it guides you through. So this is the kind of headline here. This is the last step of the risk assessment. So where the doctor or physician or PA, clinical nurse specialist, whoever's appropriate, will be completing the risk assessment and making a decision about whether thromboprophylaxis is indicated, and if it's not, why not, documenting that. The e-health record systems have also improved the way that we can communicate with colleagues. So we have like an instant message sort of system in Epic, and a lot of the other systems have a similar way of messaging, where obviously old school, it would be bits of paper, post-it notes that might fall off a paper drug chart, using a bleep system, chasing someone down a corridor, which is obviously a lot less efficient. There's a plethora of data that can be collected and analysed. So, for example, you may want to use the data to identify areas of poor practice or good practice to see what's been done, look at adverse outcomes. Perhaps you can use the data to proactively identify hospital-acquired thromboses, and using the data there to see the impact of an intervention, and how that has improved perhaps patient outcomes or reduced adverse effects. And then patient education. So this is a little example of a QR code and a web link that we have as part of a template that can go into patient communications, so patient letters or discharge information. And this is a little code that can be put in, and then that imprints directly onto the patient letters. And that's one of many examples. Can I have the next slide, Ros? Sorry. Thank you. The e-health record systems also can be used to optimize clinical decision support. So not necessarily the versions of Epic that we have in Ros, you're sharing your screen, sorry. Not necessarily the Epic version that we have, but some of the other versions have clinical decision support, where they may use AI to help prompt and alert physicians and clinicians to making decisions. So, for example, an outcome of an imaging report prompting that there's been a new VTE, or perhaps prompting a physician to review someone from warfarin to a DOAC through kind of an AI tool. But I feel like that's probably the future, perhaps in the UK, but certainly other systems do use that. We do use linked orders to help prompt physicians to prescribe medications. So this is an example. The top one is a kind of linked order that pops up when they've done the VT risk assessment to prompt them to prescribe the from prophylaxis. We also have lots of order sets. So, for example, treatment of VTE with enoxaparin, because it's obviously weight and kidney based, the order set will link through with the correct parameters. You can use hyperlinks to link through to your trust on local guidelines, so that then people don't have to necessarily be searching for the correct guideline when there may be several, or maybe easy to mispick the appropriate guideline in that place. Roz talked a little bit about dashboards, but we also use calculators, and probably the one that we use the most in the anticoagulation clinic is our warfarin dosing calculators, which has like a little algorithm in it, and it will refresh and pop up with the appropriate advice and dosing and recommend a dose adjustment for the patient based on their INR. We also can have templated orders. So, for example, if you're going to use a DOAC, then it may lead you through with the current weight and creatinine clearance, and we don't have that in our system, but I know that certain primary care systems also have those sorts of templated orders where it will lead you through the appropriate dosing, or suggested dosing, certainly. Live data reporting is really powerful. So you can use these systems to run reports and identify potentially high-risk patients. So, for example, those who are prescribed, for example, an unfractionated heparin infusion, or argatroban, where we might want a bit of enhanced clinical support, or something that's particularly risky. Or you could run a report to see everyone admitted on warfarin who had an out of range INR, for example, and therefore sort of tailor your kind of proactive support from the specialist team. Next slide, please. Thank you. Other sort of ways of using electronic systems is obviously having alerts. Obviously, alert fatigue is real. So, I've talked a lot about different pop-ups and different alerts, but we need to be aware that you don't want to have overburden of alerts and clicking fatigue, so that people actually pay attention to the things that are really important. But obviously, with anticoagulants being such a high risk area, we definitely do have lots of safety alerts. So you might have drug interaction alerts that might be flagging patients that are co-prescribed to anticoagulants. And I think this has been a common problem up and down the country, where certain anticoagulants may get started, might get switched to a DOAC after they've had some loading, and then the heparin prescription doesn't get stopped. So making sure those kind of flags come up with those big high risk interactions. Perhaps also identifying patients who've got an acute kidney injury to sort of flag that they need medication dosing reviewed. There may be aids for sort of practical operational care that might be necessary. So, for example, discharging someone on a new DOAC, you might want to pop up to make sure that they're referring patients appropriately to appropriate follow-up clinics. We have had problems with supply quantities. So again, you might want to prompt the prescriber to make sure they're prescribing the right quantity for 3 months, so that there's not problems with interface issues. And you can tailor these pop-ups and alerts to depending on what your local practice and errors might be. This is a nice example of warfarin prescribing at 2 o'clock, and I think this is more common practice across the UK now because of the potential errors where warfarin was being dosed out of hours by perhaps junior medical staff who weren't familiar with the patients. So the alerts and the prescribing for warfarin pop up and make sure that the nurses can administer at 2 o'clock. And then if the prescription isn't completed by 2 o'clock, they can then flag the day team and the doctors and the team that already look after the patient and know the patient well to prescribe the warfarin. Another example is these little reminders for therapeutic drug monitoring. Obviously, that would be really useful and is really pertinent for unfractionated heparin infusions where you may be checking ABTTs or anti-10As for your infusion every 4 to 6 hours. And then may obviously lead to a dose adjustment and then another assessment of when that next level was due. So you can use these placeholders to kind of these like dummy drug placeholders to remind the nursing staff and medical staff of how to manage those high risk infusions. So this is a nice little example of kind of unexpected consequence of e-prescribing. So this is probably an error that's never happened ever in the history of pharmacy or prescribing, but an error that's occurred inadvertently because of electronic prescribing. So this is a loading dose of rivaroxaban for an acute VTE, and the Epic system thinks it's very clever, so it's decided that it will suggest that you give 2.5 milligram tablets of rivaroxaban, so you can just provide one strength of the tablet to make up the loading dose and the maintenance dose. However, obviously, it's not ideal that the patient would be taking 6 tablets twice a day for 3 weeks and then going down to a maintenance dose of 8 tablets once a day. And we have had this occur a few times, and it's been hopefully fixed now in the back end of Epic to make sure that it doesn't think it's being clever by substituting this to make up the loading dose. But again, it's something that then has to be manually either changed by the prescriber if they notice it, or by the pharmacist when they're screening it. But yeah, obviously in a busy kind of clinic or A&E or outpatient pharmacy, it's easy for this sort of thing to be missed. If people aren't also just clicking through the screen, going through the motions, and not necessarily thinking actively about the consequences of having to take 6 tablets twice a day. So yeah, there we go. So that's you know, the e-health systems, they give with one hand and they take with the other, and they give you new errors that you never thought were going to happen. But yeah, you need to be alert to them and work out how you can solve those issues. So I'm going to move on to some case studies now. So this first case study is of a frail elderly lady who presents with a new popliteal DVT. And she's got a past medical history of Alzheimer's, COPD, osteoporosis. She has anxiety, she has glaucoma, and she is someone who has is housebound, who's having problems with incontinence and falling. So she's had 3 falls in the last 6 months, including 1 head injury. She also has a known rectal prolapse, which causes her some trouble intermittently with some rectal bleeding. So she lives at home with her also frail elderly husband, but they manage themselves with no package of care, but with some family support. So she has some baseline bloods. There's nothing remarkable on those. She has got CKD, which is probably what you would expect for a lady of her age. And she is also of fairly low body weight, 41 kilos. And she's admitted to our frailty unit and assessed for her DVT and given some additional sort of therapy support. And she's prescribed rivaroxaban for the loading dose, standard loading dose, followed by 15 milligrams once a day. And the plan is for her to be followed up with the anticoagulation and thrombosis clinic at discharge. So she presents to the anticoagulation clinic 10 days later. So she's the referral's vetted by a member of the team, and they think, oh, she's very frail, she's quite elderly, we'll check in with her sooner than we normally would. typically in our clinic, we might see someone after 4, 6, 8 weeks, depending on their risk. So she attends the clinic with her son, and she reports to be well, but she's not been eating and drinking very much. She's been taking the rivaroxaban on an empty stomach, but she's also been experiencing some large bruising on her hand. And there's a large bruise on her hand, which is from when she had blood taken during her admission, and it's really very large and it hasn't healed very quickly. She has also noted that she's had a bit more rectal bleeding than she previously had as well. And as part of her kind of baseline workup in the clinic, we did an anti-10A level because of the bruising. A little bit worried about her perhaps accumulating, especially in the loading dose phase. And so she had a level done at 6 hours post. It's not really quite a peak, it's a little bit beyond that, but it's still extremely high. And this is a little graph just showing about the usual plasma concentrations that you'd be expecting for patients either in the loading phase or in the maintenance phase at the 20 milligram dose. So she's reviewed in the clinic by the thrombosis nurse, and they have a discussion with the pharmacist and the consultant on call. And the plan is to switch her to apixaban. So it kind of goes back to what Ros was saying. I think if you're thinking about those frail elderly patients and you're thinking and considering that they're high risk of bleeding with lower body weight and perhaps other concurrent risk factors for bleeding, that instead of using the rivaroxaban at the lower dose for maintenance, you should consider using apixaban as the first choice. It'd also be, it's a little more forgiving in renal impairment as it's the least renally cleared, and therefore would be safer for her from an accumulation point of view. So she's she switched to apixaban, and then she's followed up in the consultant clinic about 6 weeks later. She's doing much better. She's had a little bit of rectal bleeding ongoing, but she finds travel to the clinic very challenging. So we continue just to follow her up by the telephone, and the thrombosis nurses are keeping an eye on her. And then there was a discussion with the consultant about whether she should have long-term anticoagulation or not. The original VTE was thought to be unprovoked, but she wasn't really for invasive investigations for any potential cancers or anything like that. But it was felt that the bleeding and the sort of detriment to her sort of quality of life was too great, and she was stopped on her anticoagulation after she'd completed the 3 months. I have the next slide, Ros, please. Thank you. So this is our treatment guideline, and so we do have a little bit in there about thinking about patients with high bleeding risk. So, for example, active cancers, those with poor oral intakes or previous bleeding history, and CKD. And we do suggest that apixaban may be preferable, and we recommend that those sorts of patients are discussed with a thrombosis SPR or consultant on call. But my recommendation if you have someone frail is to use apixaban rather than rivaroxaban for that acute treatment. I suppose the other thing to consider is about when to do therapeutic drug monitoring. Obviously all clinics would have the opportunity to do this, and it is rarely required, particularly for acute VTE treatment. We would normally go with the standard dosing. And of course, we're not necessarily going to change the dose. They are not targets, the anti-10A results. It's just really good to guide whether they're accumulating the drug or not, and whether that's linked to the adverse effect. And it's not necessarily, and there's no evidence that the appropriate range of the anti-10A is actually linked with efficacy or outcomes. But we do consider using those in low body weight patients, so less than 50 kilos. We also would consider using them in higher body weight patients, so of those over 150 kilos. Those with borderline renal function if we're worried about accumulations, those with drug interactions and absorption concerns, and also patients who have low albumin. it's not straightforward to interpret these results, and normally the results would be sort of directed by the thrombosis team, and then the result would be given, we would give advice on how to deal with the result. So either from the anticoag pharmacist or the thrombosis registrar would normally be providing those advice. Another kind of common pitfall I see with this is when they're taken before the patients reach steady state. So it's important to also consider that and make sure you're not taking it too early. You're going to need to at least, it says the 7th dose, but basically 4 to 7 days, really, depending on the drug you're using. Thank you. And this is an example of the table and why it's a little bit tricky sometimes to interpret. So this is a table that we often look at, but it gives you, as you can see, different levels and different boundaries at peaks and troughs for different dosing and different indications. And as you probably appreciate, all of those lines overlap. So a peak, you can get a random level, and you could think it's a trough, but actually it's a peak. So it can be very tricky to interpret, and it's only going to be as good as knowing when the patient's taken it and linking it, of course, with any potential adverse effects and risk of bleeding. The next case study we have is a 46-year-old male. He presents with a distal DVT. He's got an unremarkable past medical history and social history. He's married with 2 children and works full-time. He had recent travel. He went to Florida on holiday about 3 weeks ago, and he arrives in A&E on Saturday evening and is seen by a junior doctor there. He's found to have a DVT and is prescribed rivaroxaban with the standard loading of 15 milligrams twice a day, and then 20 milligrams once a day thereafter. He's only given 1 month's supply with a plan for continuation through his GP, and then he's referred to the thrombosis clinic for follow-up. You'll notice he is 110 kilos, and he is of high clearance. So there's no issue with the dose and the choice of the DOAC here. So we're happy with that. Next slide. So the referral was screened on the Monday morning by the thrombosis consultant, and he's booked to the clinic in about 5 weeks' time, which is kind of standard for routine follow-ups for this sorts of case. So he's not someone that's, again, particularly frail or would be particularly concerning. And when he's seen in clinic, he's run out of his medication a week ago. He is happy though because his symptoms have resolved, but he didn't seek any advice about his medication because he didn't think it mattered. The pain had resolved. He did ask his GP if he could add some more, but the GP said that they weren't allowed to prescribe it. But he's all been fine. The symptoms have been okay, and he's had no bleeding or bruising, and he's taken the medication as prescribed. So the plan for the clinic was really to discuss the duration of anticoagulation, and the plan was to continue just for the 3 months treatment as it was a clearly provoked event. And obviously you would then recommend some VT prevention for future provoking events. And we, as he's had rivaroxaban as his primary course, we would normally recommend rivaroxaban 10 milligrams, for example, in the event of future long haul flights. So the main root cause for this error was that he was not supplied enough medication. There's always an inherent risk with any transition of care, and whilst the communication may have been deemed clear on the discharge letter, it wasn't actually following our local care pathway. So this is a little excerpt, which I know is rather small, from our formulary, but the first 3 months for all DOACs for VTE in the Southeast London area should come from the primary diagnosing centre. So usually that would be from the secondary care A&E or ambulatory care unit. This is unfortunately a little bit different to most other medications that come from the hospitals. For a new medication would normally be 2 to 4 weeks would be supplied by the hospital, and then it would be, if necessary to continue, come from the GP. So it's more unusual perhaps for A&E and for a kind of acute medical setting. there's lots of barriers to making sure that this sort of error doesn't happen. There's obviously the access to the staff, and there's obviously always a rapid changeover of staff, particularly in A&E, where there'll be staff that work regularly on rotas that may be more difficult to access. They may have locum staff or temporary staff that will be working there. There's often different pathways, in hours and out of hours. So in hours, if this patient were to turn up, they would usually be seen by one of our VTE nurses in the like a acute nurse, advanced nurse practitioner who specialises in this VTE diagnosis. And if they were to see him, he is very aware of the pathway and would be very aware of the amount to prescribe. But out of hours, obviously that he's not necessarily available, and they would be seen by junior medical staff most typically, or more generalised nurse practitioners. Perhaps you may feel that this pathway for the rivaroxaban supply may be a little unduly complex, and obviously it differs from other local arrangements for other medications. So automatically you have something that's set up to be a little bit more complicated, and obviously therefore be a kind of risk in itself. All patients who are discharged from the hospital are given a discharge letter, and on that discharge letter there's always contact information for a medicines helpline. But as I said, often the patients don't necessarily feel that may be necessary to contact. They may not have read the letter, and they would have got an appointment for the clinic, but they may not have been able to contact or realize to contact the clinic themselves. So it kind of goes back to the kind of discharging information and education at discharge, which obviously is variable and can be affected by the staffing and the daytime versus out of hours, and depending on when the patient presented. So this is a common error that can happen. We do try and check when we're vetting the referrals to make sure patients have got enough, or certainly enough until when their appointment will be booked. And then, as I said, going back to electronic systems that can help, having specific order sets that have pre-populated quantities are really really important as well. Okay. A final case study is a 66-year-old female, and she presents with a pneumonia and with a type 2 respiratory failure, and she's treated on a high dependency unit with respiratory support. She's found to have bilateral segmental PE on TTPA about 5 days into her admission. She's got a past medical history of COPD, epilepsy, and hypertension. She works part-time as a receptionist, and she lives alone. She's a widow. She's of normal body weight. She's got normal renal function. Initially, she's given a treatment dose of low molecular weight heparin on the high dependency unit, and then she stepped down to the ward at day 8, and they start discharge planning. At this point, they switch her to rivaroxaban with the standard loading, but to complete a total of 3 weeks. The ward pharmacist, however, picks up that she is concurrently prescribed carbamazepine, and then has contacted the thrombosis team for advice. So carbamazepine, as we know, is a strong inducer for 3A4 and PGP, and can significantly reduce the levels of a DOAC, which again reduces the area under the curve, and there's a significant risk of treatment failure, and particularly in the acute phase. So we would advise in this case to continue with enoxaparin, and then to discharge the patient with a plan to initiate warfarin in the outpatient clinic. If the patient was going to be staying in, it may be that we would recommend loading warfarin whilst they were in, but we certainly wouldn't want that, only that in itself, to delay discharge for the patient. So there's, again, going back to the different electronic systems you can use. This is an example of the type of pop-ups we will get in EPIC. This obviously is different drugs, but this just gives you a little idea about the different levels of warnings that can pop up. and the advice that can come from that. So it will give you the option to discontinue. These are really good for examples where you might be prescribed 2 anticoagulants, and then you can go ahead and discontinue the other anticoagulant through the actual alert. But it also pop up with sort of advice, and you could again also use this to link to local guidelines if that's appropriate. Obviously, DOACs have many fewer interactions compared to warfarin, and I suppose this type of interaction is something that can be overlooked quite easily by prescribers, and this is why these sorts of alerts are really helpful, as particularly when there are obviously always new drugs. You know, Ros used the example of anti-cancer drugs. There's always new things coming out, and so therefore we can't possibly expect everyone to know all of the interactions with all the drugs, particularly if they are a generalist or it's a drug outside of their speciality. But this is always a role for the clinical and screening pharmacist to look at, and there's always a role for the thrombosis specialists to provide advice on managing these sorts of drug interactions. And I think in this case, alerts would be really useful. It's also really useful for, again, less common drugs. So we've had a similar case like this, where patients have been prescribed primidone, which is a very old-fashioned phenobarbital prodrug, and it's something that's very, very uncommon. And I think it was easily missed because it's so rarely seen. I think that brings me to the end, and there's just a summary slide. So anticoagulants are obviously high-risk medications, and they're commonly prescribed across a wide variety of healthcare settings, different providers. The Anticoagulation Stewardship aims to coordinate this approach for safe and evidence-based and best value anticoagulation treatments and interventions, and this should improve patient outcomes, reduce adverse effects, enhance and improve service provisions and patient education, as well as reducing cost. Hopefully you found our presentation useful, and I think we've had some questions pop in, so we can have a look at those now. It was a few about weight, I think.
Yes, sorry. Just trying to unmute myself. Apologies for mucking up the slides halfway through. So in the question and answers, do you give DOACs in patients weighing less than 50 kilos? If so, do you monitor with DOAC levels? I imagine we do the same. We do use them in patients less than 50 kilos. I don't think we have a lower body weight cutoff, really. It's kind of
No.
individualized. When do you do DOAC levels, Vicky?
Yeah, so if they are under 50 kilos, then yes, we certainly would. And we have had patients down in the 30s. But I feel often those patients, we have to be a little pragmatic with getting them to come in and so on. So that tends to be the biggest barrier. Yeah. If they're a cancer patient, they may be attending for treatment, and we can sometimes marry up their blood test with their visit, which is a little bit easier. But in those kind of very severe, frail patients, you may just stick to a low-molecular heparin, depending on the indication. And then I suppose it's a risk-benefit discussion about if it's something like AF, which I know this presentation is not about, but let's be real. A lot of the patients on DOACs will be on it for AF, and then it's like really about risk-benefit and whether that's an appropriate long-term treatment at all.
Yeah, I always have problems when patients' creatinine clearance goes below 15, and then
yes,
you're giving them the choice of not being anticoagulated or switching to warfarin, neither of which is a good choice. But yeah, there's a lot of risk-benefit discussion that goes on there. The next question is about edoxaban in high clearance. Can you see the questions, Vicky?
Yeah, I got them up, so yeah,
Okay.
I can see that. Yeah.
So is this an issue for VT that is not known, or is it that AF patients who have high creatinine clearance tend to be obese and young, and that was what contributed to their stroke risk, independent of their AF? I don't think we know. We don't. I don't. It didn't show up in the VT trials as a risk, did it?
And you would think that they'd be more likely because they tend to be younger.
Yes.
So you think they'd be more likely to.
Yeah,
have
exactly.
high clearance.
So really, I don't personally think we should be worrying about it for VT patients, but we do tend to. I don't know what your consultants think, Vicky. Do they worry
Yeah,
about it in those patients?
so I think we worry about it where other options could be used, but certainly as the example you gave, we do have patients who have high clearance, high body weight on a doxavan, for example, usually because of concurrent other medications, antiretrovirals being most likely. So yeah, I think you have to make that judgment based on that individual patient circumstance. But it certainly is not a hard and fast contraindication in my mind. We
No,
would,
no,
yeah, and
but
I think if patients are going to miss doses and you don't want to give them apixaban, I think it's a really good option from an adherence point of view, because if they're going to miss half their apixaban dosing, then you better
yeah,
give them something that's got a stronger evidence base.
yeah. For diet use in very obese patients, do you consider body weight or BMI cutoff? We use body weight
Yeah,
mostly, I would say. I mean, that's sort of a local agreement, but I think as long as you're being
yeah,
consistent.
yeah,
Um,
yeah,
and someone's just pointed out here, if 3 months treatment is prescribed for a patient and they're not followed up, the risks are, yes, that they don't get review and they're not reviewed for transient permanent risk factors. Yeah, I think this is a common problem. You have to have really strict follow-up procedures, I guess. And some people you find that have not been reviewed and have stopped or have carried on when they should have stopped. I mean, it happens
yes,
both ways, and they do need that review by a specialist. That's really
yeah.
important. Um,
So yeah, so I think it's trying to work out what you can do to support that pathway, with regards to sort of referral pathways and education, but it's going to be human error, slips, lapses in ED and in ambulatory care where it's very busy. So trying to use order sets to prompt that. Yeah,
yeah.
I'm not really sure there's a perfect solution to it.
No, and I think it's really variable in localities. Whether,
Mm,
I mean, some PE patients followed up by respiratory, aren't they, and not by, depends if you've got
mm,
a specialist thrombosis
yes,
clinic nearby. I guess
yes,
the most important thing is to have, if these patients aren't followed up for whatever inadvertent reason, that there is some easy way of contacting your local specialist to get an answer to your questions.
yeah.
And that can sometimes be difficult too. The last one I've got on the questions and answers is what duration of treatment do you offer for distal DVT patients? And that is 3 months and usually just 3 months for distal DVT. But I think there might be some more. There's some more in the
Let's have a look in the thing.
chat.
So I think we've talked about that one. Someone said about dialysis. Patients on dialysis, what prophylactic agent do you mean?
Very
I'm not.
topical.
Yeah. Do you mean? I suppose I'm going to take that as VTE prophylaxis for
Yeah,
patients who have had a VTE. So warfarin would remain sort of first line, but we're using a lot more apixaban for VTE prevention. Um, yeah, assuming that they are not on the transplant list.
yes. If you mean VT prophylaxis, primary prophylaxis, then we would use an oxyparin, and that's
Yes,
what you do too. Yes. We,
yes,
we
in the
until
setting.
well,
Yes,
we're in the process of switching because I think we're a bit behind the curve on this and have been using unfractionated heparin, but
yeah,
I think most places are now using low molecular weight heparin.
yes,
Upper weight limit for DOAC monitoring.
yeah.
There
So
isn't.
150, I would agree with that.
Okay. We
Yeah,
might be a bit more liberal on that here, but yeah, depends on the circumstances.
yeah.
Do you give low molecular weight in renal? Oh, that's the same question.
Um,
And if you do, is it non-dialysis days? We give it every day
yeah,
at 20 milligrams of inoxaparin. So I suppose
yes,
low dose
yes. And then
without
the
monitoring.
yeah, and then the low molecular heparin they have in the circuit would be separate if
Yeah,
they have
if they need it.
if
Yeah.
they need it. Yeah. So there may be patients that get both, if that makes
Um,
sense.
yes, we do full leg scans for DVT. So we find all the distal DVTs.
Yes.
Um, weight parameters when we would not use a DOAC for VTE. Uh, hmm,
Very large,
or
like
tiny
saddle PEs. Yeah. Very large PEs in very large patients.
people. Yeah. In the acute phase, particularly,
Yes.
I think, because we don't
Um,
really know.
And then I suppose this is not a weight parameter, but if people are on interacting drugs such as carbamazepine, rifampicin, something like that, again, would not use a DOAC in the acute phase, but I may do later.
Yeah. And the last in the chat just came up is enoxaparin. Oh, just commenting on using enoxaparin every day. And yes, that is true, but we piloted it for ages on our renal wards in our dialysis patients, and we didn't find any accumulation actually with prophylactic dose of 20 milligrams.
Yeah.
And no increase, no excess of bleeding. And it's quite standard practice now to use enoxaparin rather than unfractionated heparin. So yes, theoretically. And we have, we started off doing anti-10A levels and didn't find that they're any particularly high, and then have sort of petered out. So yeah. Okay.
Oh, someone's put a message on the Q&A. Sorry, last one. Often heparin infusions post alteplase for thrombolysis are quite tricky, with most users being unable to get proper levels. Could patients just get low micro heparin post thrombolysis? So yes, that's
Yes,
what we would
they
use.
do.
Yes. Yeah. So we would use that for both systemic and catheter-directed thrombolysis. And we may use the higher dose, 1 milligram per kilogram twice a day.
Yeah, I think that's what's on our protocol.
Yeah, for patients who had thrombolysis. Yeah. Enoxaparin, I'm talking about. Sorry, I don't know if I said that. Sorry. Yeah.
Oh yes, we assume everyone's using
Sorry,
enoxaparin.
we assume everyone's using enoxaparin. Yeah. Okay.
That's just what is that? Did we answer duration in distal DVT and cancer? Yes, but I guess that's a bit more complicated. Depends
Yes.
on the circumstances and the ongoing.
Risk
This
factors.
is the
Yeah,
importance of the
probably.
review, isn't it?
Yes.
At 3 months.
Probably would revert to the cancer thrombosis clinic, so possibly 6 months, depending.
Yeah. Okay, thanks everyone for listening, and I hope you have enjoyed it and learnt lots. Yeah, have a good day.
Thank you,
Bye.
everyone. Bye-bye.
Bye.